Good afternoon, everyone. Myself, Dr. Abinya, and I'm very glad and delighted to be present here during the conference, and I thank very much for inviting me here. So, you all know everything about infertility. Is just a radiological view about what we think about female infertility and how we can proceed with the diagnosis. So, first we'll go over the overview. So, first the definition and what is the incidence of the problem and what are the female factors, and then the radiological imaging and diagnosis. So, what is infertility? Is just an inability of the couple to achieve a pregnancy even after 1 year of unprotected sexual intercourse. So, there are actually two things in infertility. One is primary and the other one is secondary. So, the primary is the one where there is no history of any previous pregnancy, and the secondary is that there will be a history of pregnancy, but later they can't get pregnant for the second or the third time. So the incidence in our society is about 5 to 15% in most of the populations. So coming to the causes, the major cause is male factors, which we are going to discuss in the end of the presentation. And among the female things, the most common is unexplained, without any reason the patient present with infertility. The next is going to be anovulatory cycles, which is polycystic ovaries, and then the tubal factors, endometriosis, and mucous hostility. So coming to the anatomy, first we have to see the anatomy, and then only the imaging features will be very easy for you to understand. So this is the female pelvis, which is showing the uterus, the fallopian tube, and the ovary. So this is the uterus, and this is the fallopian tube and the ovary. So the major part of the imaging findings revolves around these three things, and then comes the cervix and the vagina. So first we'll discuss about the menstrual cycle, because this is important to see the ovulation phase of the cycle. So first we'll start with the menstruation cycle, which is the bleeding which happens for the first initial 5 to 6 days, and then comes the follicular phase. This is the phase which will do the follicular study. So the follicle will develop, and it will become a mature follicle, and then it will rupture. So that is considered as ovulation. And after that will be the luteal phase, where the endometrium gets thickened. So coming to the development of the ovum, so after the menstrual cycle, normal follicles will develop, which will be very smaller in size, and then it will develop into a very big follicle. So if it develops into a dominant follicle only, they will have a chance of becoming pregnant. The polycystic ovaries usually stop at this level itself, where the follicles won't develop. So initially we have to evaluate both the patients actually. The male as well as the female should be asked history separately as well as together also. So coming to the female history, the first and foremost history that you should ask should be the sexual function. Whether what is the frequency, how long they are doing, and how many days once they are doing. Then whether is she having any pain during the intercourse. The second is going to be coming uterine and tubal history, where you can ask whether she is having any history of pain or any infection or any surgeries which has been done in the past, and whether is she having a very white discharge or any history of white discharge in the previous 1 month or 2 months also. And the endocrine pathology, we can ask whether what is the pattern of her cycles, and whether she is gaining weight or losing weight, or whether she is having any breast milk secretion. All things will go to the endocrine pathology, and any previous history of pregnancies or not. And the most important thing is that people tend to forget about the history of contraception. Usually people will take contraceptives for 6 months or sometime, and then after 6 months they come with a history of infertility. The main reason is because of this OCPs they are taking. So that history has to be taken. So coming to the etiologies, the one is going to be the vaginal cause, where she will have only pain. If you counsel the patient will become perfectly normal. The second is going to be the congenital defects, which we can see in radiology. The next is the infections, which can be cervical, and then uterine pathology or tubal pathology, or the peritoneal ones. So basic investigations, if at all you want to rule out the other things, you can do a common blood test, urine routine, or a pap smear to rule out infection, thyroid profile, and then you can opt for ultrasound pelvis. So the basic thing is going to be ultrasound pelvis. In that itself we can visualize so many pathologies. So this is a normal ultrasound pelvis, which is a transvaginal ultrasound, where we will see the uterus. So we have two parts. The thing is that endometrium is going to be in the center, which is very important for implantation. The next is going to be the myometrium, and then this is the cervix, and these are the appearance of ovaries in the uterus, ovaries in the ultrasound. So this is the normal follicle. So the follicle is going to be this much big, then only they have a chance of becoming pregnant. The first and commonest diagnosis which we see is going to be polycystic ovaries. The thing is that the patient will present with history of delayed cycles or reduced frequency of the cycles, and the flow also may be reduced. All these things corresponds to polycystic ovary. It is just actually, it's going to be very easily treatable and very easily reversible. If you give a proper counseling or proper food habits and everything and exercise, everything, it can return back to normal in 2 months. The next is going to be endometriosis. Endometriosis, if you see any report with endometriosis, it's better that at the earliest we can opt for surgery, because this is the only thing where surgery only matters the most. Because if we leave it, every other cycle, it will just increase in size and it will be very difficult for her to become pregnant. The third is going to be uterine adenomyosis. This is nothing but a uterine echo texture which is being changed. So the uterus is becoming weak. That's what we tend to tell. The uterus will become weak, so it will be very difficult for it to hold the baby. But with proper food supplements and proper exercise and all the stress reducing habits, they can become pregnant. So coming to the next common thing is going to be uterine fibroids. Actually, multiple types of fibroids are there. Not all fibroids will lead to infertility. The one thing which is close to the endometrial cavity, this is the submucosal fibroid, is the only one which will present with infertility, because it will prevent the implantation of the ovum here. So that is the only thing which requires surgical removal. The rest of the fibroids, if proper food supplements or proper rest, everything, they can become pregnant. So this is a case. The first one is going to be a submucosal fibroid, which is that within the endometrial cavity. So this is the place where the ovum is going to be embedded. So the ovum doesn't have any space because it is being occupied by the fibroid. So for these patients, if a simple myomectomy has been done, and then even after that also she needs proper treatment, then she can become pregnant. So this is going to be hydrosalpinx. So this is nothing but the fallopian tube which I shown before. The fallopian tube will become big. The dilatation of the fallopian tube is hydrosalpinx. For this, the only thing which can be done is that the patient can have hydrosalpinx on one side or on both the sides also. If she is having one side, she has a chance of becoming pregnant through the other tube. So we can give proper counseling to her, and then she can become pregnant. The next is going to be pyosalpinx, which is nothing but infection of the normal tube. The dilated tube will become infected. For this patient, it's going to be very difficult that she cannot become pregnant because the whole tube is gone. So this is a normal common infection which you will see in all the females. They present with increased white discharge. So because they don't properly maintain menstrual hygiene, that is the only thing that they develop this cervicitis. If this is being treated, then the patient can easily become pregnant. So this is the uterine anomaly, which is the congenital anomaly of the uterus. So this is going to be a normal uterus which you will see in ultrasound. This is actually a 3D image which is very useful to detect the anomalies, and this is a bicoordinate uterus. The thing is that normally all the females will have one uterus, one cervix, one endometrial cavity, two tubes and two ovaries. But these anomalies will have they will have two uterus or two endometrial cavities or two cervix. So all these, they will have difficulty in becoming pregnant because the angulation, everything will be different, because they have two endometrial cavities. The ovum has to be implanted on one side, and that side the sperm has to enter. So this is going to be, they can become pregnant, but it will take some time for them to achieve it. So this is the normal thing which we send for everyone. That's a follicular study. So usually we'll send the follicular study from day 9th or day 7th. But nowadays there is a recent update is that we can do an antral follicular count. So this is the antral follicular count. That is nothing but we are going to see whether the ovaries will have proper follicles or not. So if the follicles are less, then whatever we do also she can't become pregnant, because inborn, due to some things, her ovary is being affected. So she can't even become pregnant, because there won't be any follicle for her to develop. So the normal is going to be 5 to 10, at least 5 to 10 should be there. and which is done on the second day of the menstrual cycle. If we done later, then it's going to be, it doesn't have any significance. Only on the second day, we should do a transvaginal scan, not a transabdominal scan, transvaginal scan. So if you want to send for any follicular study, it's better to send the patient on the second day also, and then we can do the follicular study. Because if at all in the initial time, if I give you that ovarian reserve is very less, then it's very difficult for her to become pregnant. Even with all the proper treatments or whatever we do also, it can't be done. So next is going to be the follicular study. Here, from the 7th to 9th day of the cycle, we'll do serial follicular monitoring. I usually prefer 9th day of the cycle. The follicle usually grows by 2 to 3 mm per day, and we'll do on alternate days, or we can do continuously. It depends upon the person who is doing, the radiologist that is doing, because the size, sometimes it can be 1.8 centimeter on one day. The next day it will become 2.2 centimeter. We can't expect how much big it becomes, because till if it's only 2 centimeter only, the follicle is very viable. If it crosses the level of 2 centimeter, that follicle, that ovum is not viable. Even if it ruptures also, the chance of becoming pregnant is very less. So it's going to be at 18 to 20 mm maximum, then only there is a very chance of becoming pregnant. That's why we are doing the follicular study. So this is how we do. See, with this we will see on 9th day, where we will see number of follicles which is very small in size, and later by later it will become big. Only one among the follicle will become very big and it will rupture. The second is going to be, even if the follicular study is normal, but the patient still can't become pregnant after 1 month also, then we can offer HSD, which is hysterosalpingogram. It is just a very minor procedure where it's we do to examine the uterus and the fallopian tubes. The indication is to see the uterine morphology as well as the tubal patency. The uterine morphology can be detected in ultrasound itself, but the tubal patency can be seen only in hysterosalpingogram. So even with the follicular study is normal also, the tubal patency, if it's not there, she can't become pregnant. The contraindication is pregnancy and any other pelvic infection. If it's there, if we do the procedure, the infection will flare up. So this is the normal uterine HSD procedure. What we do is we'll just insert a tube inside the vagina and we'll inject the contrast and we'll see the X-ray. Yeah. The contrast will go inside the endometrial cavity. It will go into the fallopian tube and will come out. If it comes out, then it is normal. If it doesn't come out, then there is some block in there. So this is a normal HSD where we'll see the endometrial cavity. This is the fallopian tube and this is the spillage. The spillage indicates that it is normal. Then she has very chance of becoming pregnant. If the spillage is not there, then that comes the other diagnosis. So this is the first diagnosis, which has got to be hydrosalpinx, which I have told priorly itself is a dilatation of the fallopian tube. See, for this patient, there is two sides also, there is dilatation. So the ovum can't enter the endometrial cavity. So for her only, it's IVF treatment is mandatory. If at all hydrosalpinx is given on only one side and the other side is normal, you can wait and become pregnant even after 1 or 2 months. But if both the sides, if they have given hydrosalpinx, it's better to go for IVF. The second is going to be tubal irregularity, which means that she is having some infection within the uterus, which has to be treated. Okay, this is the this is the one which presents with every patient. So this is going to be the block in the tubal, in the fallopian tube, that is block. So if the block is released, then she can become pregnant. With this procedure itself, usually the block will be released. If it's a normal block, it will be released. But here the left side, the hydrosalpinx is there. So this left side tube is gone. There is no use in that. So you can try for this right side. Even if you go for a simple procedure to remove this, then she can become normal pregnant. And this is going to be tubal block. The tube is normal, but the end only is the problem. So there is no spillage outside. So the ovum can't come inside. If there is spillage only, the ovum can enter from the ovary into the fallopian tube. So this is blocked, then the ovum can't enter. So this also is just a minor procedure which can be done so that she can become pregnant. And this is going to be sine A. If she has any history of previous abortions or any DNCs which has been done, even one DNC will produce scar. That will prevent her from becoming pregnant. So usually DNCs should be avoided. If at all she is undergoing DNC, she has to do proper treatment because the adhesions should be released for her to become pregnant. And this is going to be a simple polyp which is actually benign. It is normal, But the thing is, it will prevent the ovum from developing within the endometrial cavity. So just a minor procedure to remove it, then it will be normal. Not all patients will present with endometrial polyp or submucosal fibroid. Only 2 to 3% of the patient will present like this, which will need procedure. For rest of the patients, we can just follow up. So this also, I've told us uterine adenomyosis where the uterus becomes weak. So that also she can also become pregnant if with proper treatment. Okay, so this is how we deal with it. So if we do a normal ultrasound and the ultrasound is normal, the ovaries is normal, the uterus is normal, there is no problem, but still she is not getting pregnant, we can offer HSD. In HSD, if you are seeing any tubal block, you can directly go for MRI. Or if tubal irregularity is that which is mentioned in the report, you can treat for the infection. The third is peritubal abnormalities which cannot be seen in HSD. It can be seen only in MRI. That is this endometriosis or pelvic inflammatory disease. So first we will go with the ultrasound and then with the follicular study. If that is also normal, we will go for HSD. Even HSD is normal, we will go for MRI. So this is the normal MRI pelvis where we can see the entire uterus and the reproductive system. So this is going to be the uterus, this is the cervix, and this is the ovary. So the main thing which we prefer MRI is the uterine anomalies, because if we see the uterine anomalies, even in ultrasound also it won't be definitive. So we have to do an MRI imaging to confirm it, because few of the anomalies they can become pregnant. For the rest of the anomalies, if the uterine anomalies is there, we have to do a surgery, because in the future she can face any abnormality, she can face any complications. So usually we will present with unicornuate uterus where the uterus, the shape will be very much changed. The second will be bicornuate where there will be two uterus will be seen. Two uterus, two endometrial cavities. So even if she gets pregnant with one uterus, the other uterus will bleed. So she should be properly treated, because that will produce hormonal irregularities and she can go for abortion. And the third one is a septate uterus, which is the most safest uterine anomaly, because septate uterus, the only problem will be she may have recurrent miscarriages, but she can become pregnant with proper care. And the next is going to be the polycystic ovary, which I tend to tell. So this is the most common thing which you will see in 70 to 80% of the patients. Usually that is because of lifestyle modifications, obesity, stress, and without any lack of physical exercises. So the ovaries will be very bulky. The only abnormality is that the follicles multiple will be there, more than 20 or even 30 also will be there, but there won't be any single follicle which will develop. So if it becomes big only, it can go for a fertilization, but it won't become big. So with the proper lifestyle modification and follow up, in 2 to 3 months she can become pregnant. The second is going to be endometriosis. So this is why the surgery only is the only treatment, because endometriosis, if we leave a rare possibility that she can become normal, she can become pregnant. But the thing is that even surgery also, if we miss in one cycle also, it will multiple. So even after that, if we leave for around some 6 months or 8 months, then even surgery won't be a choice for her. So she can go only for in vitro fertilization. So this is going to be uterine adenomyosis where if we give also, it considers okay only, it's normal only, she can become pregnant. It is not a pathology, it's not a disease. It can be easily, even if it's there also, she can become pregnant. The fourth is going to be uterine fibroid. Only if the fibroid is there within the cavity, that is submucosal fibroid is given only, you can offer treatment. Otherwise, she can normally become pregnant. The only minus is going to be with the pregnancy and the hormones, the fibroid will also increase in size. That may pose some difficulty to the baby, which we do in the follow-up imaging. So if in the follow-up ultrasound, if we give there is increase in the size of the fibroid, we have to be careful in explaining her that she has to take bed rest, she should not move, she should eat healthily, and then it will be normal. She can go with the pregnancy. So the last one is going to be the cervical stenosis. Actually, the patient will present with, she can have normal bleeding also, normal menstrual cycle also can be there, but she cannot become pregnant. That is because there will be the cervix is closed. Only some part of the cervix will be open where the bleeding can happen. So for this thing, only if you insert a catheter, that's all. Catheter and dilate it, she can become normal. So this can be imaged only in radiological imaging and not with the clinical findings. So this is about the female infertility. So you can go for the ultrasound. If ultrasound is going to be normal, then you can go for the follicular study. In the follicular study, antral follicular count on the second day is important. Even if the follicular study is normal, we can go for HSD, which is hysterosalpingogram. Even if that is normal, and if at all any report suggested MRI has been given, MRI pelvis has to be done because that is mandatory. So coming to the imaging of male infertility, so this is going to be the bladder. So from the first we'll go from the down. So this is going to be the testicle. From the testis we'll have epididymis, then the ejaculatory, we'll have the vas deferens, then the seminal vesicle, ejaculatory duct and the prostate. So if there is any block in the whole tract, he will present with infertility. So for this to diagnose, we have to do a scan. The first thing before scan itself, we have to do semen analysis because the most common cause is idiopathic. The next is going to be varicocele. Varicocele is nothing but the dilatation of the veins. And then is going to be the semen disorders, testicular failure and obstruction. The first and foremost thing which we can do for a male is going to be the semen analysis. Usual protocol is semen analysis has to be done once in 3 months for 2 times. So the first, if he comes today, we have to do a semen analysis, and then after 3 months again we have to do a semen analysis. Because if it's abnormal in the first time, it can become normal in the second time. And vice versa. If it's abnormal in the first time also, it can become, if it's normal in the first time also, it can become abnormal in the second time. So for the semen analysis, we will check the volume, how much ml is secreted, and what is the count, whether it's more than 20 million or not. If it's less than 10 million, it's going to be oligospermia. Then there is a chance of becoming, he has a chance of becoming infertile in the future. If it's 0, then he can never become, he can never become fertile. So with the semen analysis, we can come to a conclusion whether we can do something to him or not. And motility also plays a major thing. If it's motile only, we can proceed with the normal pregnancy. So the basic ultrasound we can send for is ultrasound scrotum, where the most commonest finding is going to be varicocele. Nearly around 50 to 60% of the males will present with varicocele. But it can be the grades are there, actually 4 to 5 grades are there, which initial grade 1 or 2, he can have a normal fertile life. But if it's grade 4 or 3, it's going to be very difficult because the sperm count is going to be reduced. And for varicocele, the treatment is only surgery, where we can either aspirate the veins, we can aspirate the blood from the veins directly, or we can do a venous transplantation. And the second is going to be cryptorchidism, which is going to be detected only in the earliest age, because the testis usually, so this is the image. The testis actually develops from the abdomen, and then by the days the child grow, it will come down to here. So from the abdomen till the scrotum, it has to come down. It will take some time. If at all it doesn't come down, if it's stuck somewhere, then it's called as cryptorchidism, which is nothing but undescended testis. So here, this is a scrotum, where you are seeing one testis on one side, the other testis is not there. It's there in the abdomen. For this patient, the testis has to be surgically removed and placed within the scrotum. If not, he can develop malignancy, he can develop cancer in the future. And the chance of infertility is also more. And this is going to be ectasia of testis. So this is a pathology where there is some block in the tract. There is some block within here, either vas deferens or here the ejaculatory duct or in the seminal vesicle, some block will be there, which is causing block here. So all the sperm will be collected here itself. So if we do a proper aspiration, we have to just aspirate the sperm. The sperms will be settled here. If we do an aspiration, needle aspiration, he can become fertile. The next is going to be infection. This is epididymitis. The most commonly they present with this infection because they wear tight inners or tight clothes, which is to be avoided. If we avoid this simple thing, they won't present with any infection or inflammation. So this is going to be a cyst. So this is actually normal cyst, but this occurs because of any block in the tract. So this also has to be treated for the sperm count to be increased. And this is the same, dilated vas deferens. This is one is microlithiasis there in the testis. These people can be fertile also and they can be infertile also. The only thing is that these people are more prone to cancer in the future. In 10 to 15 years, they will present with testicular cancer. So this is a very small finding, but if you don't do follow-up imaging, then they will present with cancer 10 to 15 years later. So this is a cancer which is present within the testis, which is called as seminoma. For this, he has to surgically remove all the structures here, and then only he can proceed with a normal life. So this is an ultrasound abdomen also, where there is a cyst within the prostate. This also prevents the sperm from coming out. So if this cyst has to be aspirated, then he can have a normal sperm count. The last one is the very rarest possibility, where we present with endocrine abnormalities. There is a lesion, there is a cancer which is there within the brain, which will present with infertility. So if he has a proper history, like whether he is having loss of hair or increased hair growth, or there is a change in the voice, or there is development of female characters within a male, or development of male characters within a female, so development of organs is also different, then we have to think of this pituitary abnormality. If we do an MRI imaging, we can diagnose. Actually, it's a very small lesion, but the findings will be very much different. So the lifestyle of the patient will be altered. If we surgically remove this one small thing, he will be perfectly normal. And thank you. So if at all you have any doubts or any related to gynecological or obstetric procedures or any findings, you can directly call me anytime. And I'm going to be available at Abhi Scans and Labs. And if you have any doubts now also, I can clear it off. If anyone having any doubts.
Thank you for wonderful session, ma'am. Any doubts?
Yes, ma'am. Thank you.
Ma'am, how many times we can ask for an HSG if we have any doubt?
HSG once is fine, ma'am. Only once is more than sufficient.
Okay.
If in one HSG, if you are feeling any abnormality, that is going to be permanent.
Okay.
If you want to do a repeat HSG, you can do after 1 year.
1 year. Oh.
Preferably, because every time if we inject also, she can develop infection and she will have severe pain also.
Okay.
But it's a simple procedure which can be done, that's all.
Okay. Okay. Thank you.
Thank you, ma'am.
Any more doubts, please? Ma'am, that was very wonderful presentation.
Thank you.
I'm having a doubt that we have seen a patient where the follicular growth was seen like 1 mm per day. She was having a 28-day cycle, and 12th day the ovulation was happened, but it was only 12 mm.
Okay.
So can we consider it as a normal, because her hormone?
No, it's not normal, because 12 mm if it ruptures also, the ovum is not properly developed. So for her to produce a normal ovum, a very nice ovum, for it to be fertilized, it should be 18 to 20 mm. So if it's before 18 mm also, if it ruptures also, it's of no use. And after 20 mm also, usually commonly I see the scanner, I'll see at 25 mm or 22 mm. After that only it will rupture, and then they won't become pregnant, because at that time also the ovum will lose its virility. So it has to be between 18 mm and 20 mm. If it's not happening between this measurement, then it's going to be very difficult. Then she has to wait for the next cycle only. Okay, that's what we tell. The follicular study was important. We can do the follicular study any number of times, because it's a normal ultrasound only. The next time we have to properly see, okay fine, if she is getting, if the rupture is happening at the early stage, we have to be waiting. We have to do the scan at the early also. For some people, the ovulation can happen at 12th day. Some people it's 14th day, or some people it can happen at 20th day also. But the size only matters the most, which we can see in the follicular study.
Ma'am, then one more doubt. I have heard about this vascular polarization is very important for this growth of follicles. I have heard about
vascular what?
Polarization is very important for the growth of follicles. I have heard somewhere in.
Actually, I don't hear. I don't understand that, and I have not heard about that. So can you explain in detail? Because
no, ma'am, I don't know actually in detail about it, but I have read in some book that it is about the blood circulation around that follicle. That is very essential.
Okay, fine. Actually, for the follicle to develop, blood supply is important only, but more than that, nutrients is going to be important, and stress also should not be there. Hormones play a major role. If she is stress-free and she is normal, the hormones will be normal, the vascularity will be normal, and the follicle will also grow normally. So only that is going to be there. The major thing is going to be stress only. Because if the patient is getting more stressed, the follicle won't rupture. Even if the vascularity is normal also, the follicle won't rupture. So it depends upon the person's stress and the person's nature, how she is going on with the cycle.
Thank you.
Thank you. Ma'am, she has to. Yes, ma'am.
Ma'am, any particular pathology we have to expect if the follicular size is more, maybe that more than 30, 32 and like
the
that?
thing is only stress only, ma'am. She is actually stressful. That is the only reason why the follicle is becoming very big.
Not other pathologies.
Stress is gonna be major thing, and nutrients. The food which she is taking. That also matters the most. Main thing is stress only, ma'am, because we females tend to become more stressful over this. If we tell a follicular study, the patient will think about that itself, and then that will become stress, and the follicle will increase in size. So if she is normal, if her body temperature, everything is normal, the growth will also be normal. If she is stressed, the temperature will be altered and all the hormones will be altered. So that is the main thing why people tend to have this polycystic ovaries also.
Okay, thank you.
Thank you.
Very nice presentation, ma'am.
Thank you, ma'am.
Ma'am, in the case of salpingitis,
Yes, ma'am.
to know about the involvement of tubercular origin,
Yes, ma'am.
is there any procedure other than laparoscopic invasive
No, ma'am.
methods?
Basic one, Manto test is more than sufficient, ma'am.
But Mantox is not always.
Manto will not be positive always, but with the radiological imaging, if we give it as going to be any salpingitis, unless and otherwise food, it's going to be tubercular only, ma'am. Because no other infection will affect the fallopian tube in our city. In our country, it's going to be tuberculosis. So, but we can't treat for the tuberculosis also, because she would have the infection long back. This is just a sequelae of the infection. So now what we can do is that if she's having active infection, if Manto test is positive, she's having active infection. For that, anti-tubercular drugs should be given. If Manto is negative, she would have infection long back. So that tube is gone only. She can't get pregnant to that tube, but the other tube will be normal.
So while we are doing, if there is a tubercular origin,
Yes,
but we are posting for HSG. While we are doing, whether we will be creating an infection?
No, ma'am, because already her infection would have been settled. She won't even present with any symptoms only. She would have infection around some 5 to 10 years back also, because if there is active infection, she will have cough, fever and everything. Usual of the females will present with infection long back, which they won't even understand they had or anything. With the imaging only, we'll tell that she had tubercular infection long back. So we'll do, this is the protocol, we'll do a Manto test. If it's positive, she should get the proper treatment. If it's negative, we can try pregnancy to the other tube. Because this tube is not viable. Because once infected, that scar tissue will be there and the ovum can't travel. So that, the other tube we can try. Thank you. Sure, thank you.
How to differentiate between if it is even gonorrhea can also cause sulfate?
Yes, sir. But gonorrhea usually presents with the cervical infection, sir.
Okay.
So cervical infection definitely she will have active infection.
Okay.
So she will have any white discharge, and if we give antifungals or anti-inflammatories, she will have settled. Tuberculosis is the only thing which will produce long-term findings, sir.
Okay.
That is the thing. Once infected, she is gonna have the findings for long time, even after 15 to 20 years. Gonorrhea is gonna be acute thing, sir. It won't produce major problems in the future. At that time, if we treat for the cervicitis, then it's gonna be fine.
Thank
you. Thank you, sir. He's gonna be.
Namaste, ma'am.
Namaste.
Ma'am, my question is diffusion weighted imaging.
Yes.
Like, what are the signs to tell the masses is benign or it is malignant?
Okay.
And also, what are the clinical signs we should look after if there is fetal growth restrictions during pregnancy?
Okay. So both the questions are different. So I'll explain one thing in detail. So for MRI, you have asked for the diffusion weighted imaging. So that is just a sequence that we do in MRI. So for gynecology or obstetric related, if she is having any malignancy, any cancer, it's gonna be showing diffusion restriction, diffusion weighted imaging. The rest of the findings, rest of the diagnosis, it doesn't weight any significance. Only if she presents with malignancy, this DWA or diffusion weighted imaging is gonna be useful. The rest of the things it's not useful, because for all the patients which we come, we will do DWA, but it has only significance with malignancy. Even endometriosis can show, but endometriosis is nothing but a blood inside the cyst, so which we can detect without DWA itself. DWA doesn't do any significance. Only with malignancy, not only in pelvis, everywhere in the body, diffusion weighted is used only for malignancy or any infection. Like if she has developed abscess or which I have showed pyosalpinx, that also DWA can be used. The second thing is going to be fetal growth restriction in obstetrics. Yeah. So if you are seeing a pregnant lady, she is going to be normal. Usually this fetal growth restriction happens only after 20 weeks. Maximum 20 to 30 weeks. After 20 to 25 weeks only she will develop this growth restriction. Before 20 weeks she will be perfectly normal and the baby will also be normal. So she will have for every week her abdomen has to grow, which is a direct indicator that the fetus is also growing. So if you see her abdomen is not growing, if her abdomen is not bulging out, that is a indirect sign that fetus is not growing properly. So you can directly go for ultrasound. This is the only with the abdomen size you can detect any fetal growth restriction is there or not. And in radiologically, we can see the baby growth is abnormal and the baby's blood flow can be altered. Everything can be seen in ultrasound itself. So ultrasound values the most for obstetrics. But in ultrasound only you can detect fetal growth restriction is there or not and whether this fetus can survive this pregnancy or not. If the fetus can't survive pregnancy, the blood flow and all the vessels and the Doppler will be altered. So if you suspect fetal growth restriction, you can write for an obstetric ultrasound with Doppler. So with Doppler values most, because not all radiologists will do a Doppler for all the patients, because it's kind of a tedious thing. It will take some time to take all the flow and everything. So if you mention obstetric scan with Doppler, then only we can easily detect this fetal growth restriction. Even if we see, even if you're not writing the Doppler and the radiologist is seeing and she has just mentioned as fetal growth restriction is there or not, but she has not done Doppler, we can't expect that the baby can die the next year also. The baby can die after 1 month or even 1 week also. So the Doppler values the most. So nowadays for all, we do Doppler for all the patients. After 24 weeks, we'll do a Doppler for everyone. But not everywhere they do the Doppler studies. So it's better to do a Doppler along with the obstetric scan because easily the baby growth can be normal, but the blood supply and flow can be abnormal, which can lead to death of the baby. So which can be detected only with the Doppler. So obstetric scan with Doppler values most. So that can be used to detect all other anomalies, even fetal growth restriction, where the fetal growth will be normal, but because of blood pressure increase, hypertension of the patient, the baby will be affected. Everything can be detected via this Doppler.